Hello, everyone, and welcome to the latest edition of Seconds Count. This is the podcast of the Northern Ireland Ambulance Service, where we aim to bring you behind the scenes of what happens on a daily basis within our service. Today, I'm joined by Michael Allen, who is our Community Resuscitation Lead. Very good to have you here, Michael.
Thanks for having me, John.
Thank you. We're going to explore in depth possibly the issue of out-of-hospital cardiac arrest and the role that the public can play in increase the chances of survival for anybody who might suffer from such an incident. But before we go there, let me ask you a question. Which is more serious? Is a heart attack more serious than a cardiac arrest? Is a cardiac arrest more serious than a heart attack? Or are they the same thing? Take 5 seconds and just think of your answer. Okay, so you've locked your answer in, as they say on some of these Instagram posts. But Michael, we'll let you explain which is actually more serious.
Well, fundamentally, they're very different, John. Clinically, they're very different. So a heart attack is essentially a problem with the circulation, where there's a blockage, primarily in an artery of the heart, which stops the blood flowing to the heart muscle. So that muscle eventually will die, causing the pain. But the person, their heart is struggling, but it's still beating. Mm-hmm. They will still be conscious through it. That it can lead to a cardiac arrest, but a cardiac arrest then fundamentally means that there is no heart activity at all. The heart has arrested, it has stopped. So therefore, much more serious.
So the answer to the question is cardiac arrest is by far the more serious. People don't actually die of heart attacks. You know, people say, oh, he died of a heart attack, he died of a heart attack.
Correct.
A heart attack might have been the preemptive bit, but it got worse and deteriorated into cardiac arrest.
Led to a cardiac arrest if treated.
In Northern Ireland, out-of-hospital cardiac arrests, we still have a serious issue with out-of-hospital cardiac arrests. How many are there in Northern Ireland each year?
So on average, there's about 1,400 out-of-hospital cardiac arrests across Northern Ireland.
And where do these take place mostly?
Surprisingly for some, most of them take place in the home. Statistics are hard to put an exact figure on, but it can be up to 80%.
80% within the home.
Within the
right. So, and where did your interest come in this field?
I suppose having been operational in the ambulance service for a long time now, what they would have historically called an old hand, I am now. I suppose the shift went from going out and treating that in the initial phases to the preventative measures and the education to the public, and I suppose the awareness that those public interventions, those early public interventions, were the ones that can actually make the difference to survival from an out-of-hospital cardiac arrest.
So what are you saying, the public interventions, what are you asking people to do?
So basically, what we teach, and it's worldly accepted, particularly across Europe, it's championed. They call it a chain of survival. And there's 4 steps to the chain of survival. It actually came from the American Heart Foundation in the 80s. It's been adopted by the European and the UK resuscitation councils. And it's really the gold standard of what should happen to lead to survival from out-of-hospital cardiac arrest. There's 4 steps. The first one's recognising a cardiac arrest and calling 999.
And how do you recognise it? As a member of Joe Public, how do you recognise it? How is it different to somebody who faints?
Yeah, the difference is that your breathing would be inadequate, is the wording from the latest Resus Council update. So if it's inadequate, you should then start CPR. And I suppose what's inadequate? Effectively, you should be breathing at 12 to 20 per minute. So if you're breathing at less than that, it's inadequate, and therefore you should start CPR.
So it's recognising inadequate breathing to start
with.
Okay.
Yeah.
So what's the second chain?
The second one is starting CPR. So that's your second part of the chain. And obviously, once you've called 999, the call handler will direct you to how to perform the CPR if you're not proficient yourself. So They'll guide you over the telephone and coach you through it.
Okay.
The third step of that is retrieving an AED and giving defibrillation, which obviously then, contrary again to what people think, it doesn't restart your heart. At a split second, it will actually stop the electrical activity in the hope that it will revert back to a normal rhythm.
So can you go over that a wee bit more detail for members of the public? An AED will stop your heart.
Yeah.
What's the benefit of it stopping the heart?
So in a cardiac arrest, the electrical activity that I'd mentioned, which was different to the heart attack, the electrical activity isn't sufficient to maintain a normal heart rhythm and a normal output for the heart. So whilst it's in, there's certain rhythms which you can shock and certain which you can't. Those which you can, the AED will identify those and it will only shock those. And that's where it will stop the electrical activity for the brief second. It's like a reset button,
Right.
if you imagine on a computer,
Sure.
to try to revert back to normal.
Okay. And the AED, what is an AED?
So it stands for Automated External Defibrillator. And essentially what that is, it delivers a current through the heart to stop it for that brief second in an attempt to revert to normal rhythm.
So is that the same as what the ambulance crews bring in with them? You know, because the ambulance crews, if anybody's ever seen it, they'll stick pads on you and they will look at a rhythm first and they'll make a decision.
Yeah.
Has this bystander to make a decision as to whether?
No. So an automated defibrillator, obviously automated means there is an input from a user. However, the analysing of the rhythm is all done by the defibrillator, the automated defibrillator. They will coach you through the CPR. There's a metronome, and then after 2 minutes, it will say it will analyse the rhythm, which the ambulance crew would do manually.
Yeah.
It will automatically do that and decide whether shock is advised or not. If it is, it will ask you to stand back, press the shock button, and then straight back into CPR.
So it actually tells you to do that.
Tell you, your voice prompted.
So I'm just thinking, for members of the public watching somebody and that's playing the panic, it must be very comforting to know that it's not their decision whether they're going to shock, it's the machine's decision. Right?
Absolutely. And I think that's a misconception that using an AED is scary. If you're not trained, you'll not know how to use it correctly. There really is no training because it's voice prompted and it's designed that way. There's audible prompts, and with some there's actually visual prompts as well.
Yeah.
Each of the pads that you're placing have a picture of where to put them on the chest.
Right.
And it is designed that anyone can use it.
Okay. And then what's the fourth chain of arrival?
That's advanced care, and that's really ambulance arrival. So if you think about that, there's those 4 steps, but the first 3, the public and the community can do all of those prior to ambulance arrival.
Yeah, but you know, watching somebody collapse in front of you and wondering what to do apart from phoning 999, and then the call taker's going to ask you, you know, about the AED, but they're going to ask you to do CPR. You know, a lot of people aren't trained in CPR. How can they take on that responsibility? Because you know yourself, some people say, "Oh, I'm afraid." Why would they be afraid, first of all, and why should they not be afraid?
Well, the first thing, I suppose, is the confidence that they haven't been trained. And to mitigate that, that's where the call handler will talk you through exactly where to put your hands. They'll count you through the rhythm of when to press. They'll count with you 1, 2, 3, 4, and then 1, 2, 3, 4 to keep you right and keep that rhythm correct. They'll tell you how deep that you should be trying to press. So effectively, they'll do the best telephone CPR, I suppose you could call it. There's other barriers, I suppose. People historically would think, well, what if I do it wrong? Will I make that patient worse? Could I be sued for stepping in and maybe causing damage, breaking a rib, that sort of thing? Okay,
so somebody's had cardiac arrest. How could you possibly make somebody worse? Because people are going to sit and think they're doing CPR and they're going to hear crack. Oh, I cracked that man's ribs, you know, that woman's ribs, whatever, you know. Is that what they're thinking about? And
it's exactly what they're thinking about.
What do you weigh up?
Balance that out. If you don't do CPR, they will not recover.
Mm-hmm.
If you do CPR and break a rib, they'll recover. With a broken rib, they'll heal. You'll not heal from a cardiac arrest, but you'll heal from a broken rib.
Yeah, and I suppose it's the memory that most of these IEDs happen within the home, so it's actually your relative whose life that you are playing a part in actually saving to make sure they're around. What is the survival rate of out-of-hospital cardiac arrest? You said there's 1,400.
So there's 1,400. They aim across the UK, and we're pretty much similar to those other trusts where they do measure it. But we aim for 10%. We're slightly below that, but the aim for the UK is to be 10%. So that 1 in 10 chance of survival, which is still low, but compared to where we were, and I suppose until we started to measure that and create a registry for that sort of information, we weren't really sure where we were. So from the baseline, we have already improved. So we're already going the right direction.
So then, in terms of, I remember way back in the mid-teens of the century, the department launched a cardiac resuscitation strategy.
Yeah.
You know, and what was the vision of that? To obviously take it from that 10%.
Well, at that point, we didn't even have a figure. Effectively, it was to increase the amount of people that were trained in CPR, confident to step forward and perform CPR, accessibility for public access defibs, to increase that, and ultimately to increase survivability from out of hospital cardiac arrest. They were the key component. Long document, but
yeah, no, I get that. So if I take the first two of those, right, increasing the number of people trained in CPR, obviously the ambulance service will always take time. We will aim to be there within 8 minutes. Now, I suppose it's a good time to say, why do we set an 8 minute target? Why is it 8 minutes?
Well,
isn't it to do with the every minute that passes, there's a 10% less chance?
So, I mean, you have to, I suppose it's what would be deemed achievable. So, as you say rightly there, for each minute that passes without CPR and ultimately defibrillation, every minute you've a 10% less chance of survival. So even at that 8 minute response target time, if you count that from 100% at the start to ambulance arrival, you're down to a 20% chance. And really, without those early interventions, as an ambulance service, we would have historically very little to work with, and that's the vital importance of those early interventions.
Yeah, I suppose it's important to say at this point that 8 minutes is a target, but we don't say, oh, we'll be there in 8 minutes. We try and get there as quickly as we possibly can. The quicker we can get there, the more the chance of somebody has to survive it. But there's always going to be a slight delay, which is why we want more people trained in CPR. What has happened since the introduction of the community resuscitation strategy?
So there's been lots of things introduced. One, I suppose there's lots of strands to realize that is my role in my post now as community resource lead. One of the sort of more structured things would be the like of community of lifesavers within schools. There was no formalised schools programme before, so a train-the-trainer model was set up. And I suppose it's on the back of the legislative change really that came in 2022, where it was mandatory for pupils to receive CPR and AED awareness training within school.
And does that happen?
That happened in 2022, and it started then. There were other campaigns before that, like if British Heart Foundation had a Heart Start campaign and things like that, but it wasn't legislative that it had to be delivered.
So every student in school in Northern Ireland here is receiving CPR training?
Absolutely.
And how does that manifest itself? Is it at a certain stage? Is it post-primary or is it primary?
So what's agreed in legislation is post-primary, and it's at key stage 3. So that's year 8 to 10 or first to third year in old money.
Yeah, no, I remember those very well. Yeah.
So they have to receive it during that time now. Within that, we do a train-the-trainer model, and we coordinate that through the EA, the Education Authority. And we offer sessions throughout the year for teachers to attend. They then become trainers as we've trained them to become trainers of CPR. They'll take that knowledge back and deliver it within the schools.
So the vast majority of the training within the schools is done by teachers because they're on the ground.
Absolutely.
Is it, just my own knowledge, if you get that training in year 8, do you also get it in year 9 or 10, or are you checked off as having received that training as a one-off?
Therein lies the problem. It's not standardised. So some schools, they may already have some good resources. They do have maybe more drive or more capacity to maybe implement a program of maybe 4 to 6 weeks where they'll do it once a week for that time. They may revisit it again sort of after a year 8 in year 10. Some will, I suppose, they'll tick the mandatory box and say that they have received it during that time. I would like to see it a bit more standardised.
Yeah, I'm sure you would. And is there not a gap then? Because with greatest of respect to anybody who sees that as key stage 3 work, young people are going to be out and about in the public domain from year 11 onwards. They're more likely to come across something there in the household, family, any age at all. The benefit of having that training is fine, but what is there anything that caters for the years 11 to 14? So especially when you get the year 13 and 14 where they are out on social nights and things can happen.
So within the school setting, no, there isn't. However, last year there was a collaboration with other UK services, the like of Save a Life Scotland, Save a Life Wales, the Resource Council, British Heart Foundation and ourselves. and collaboratively we put forward a proposal that it would become included in the driving theory test question pool.
Right.
And that actually, it comes into effect this year. It has been in the questions for people that they can access those up until now. And from this year, you can now be tested on it at that theory stage. So anyone learning to drive effectively has to learn about CPR and AED awareness as well.
And that would be, it's a good starting point, but actually, I'm sure you'll agree, is the practicality of doing the CPR.
Absolutely.
If you learned in year 8
Yep.
and you're 19 years of age at university and you've never heard it since, you're still going to be as fearful as anybody who's never had CPR training.
It's the old use it or lose it thing. And if it's not hands-on and the practical and the muscle memory of doing it. So I mean, certainly I would say a framework throughout school is being the way forward.
Yeah.
Much as some of the other sort of the countries with the higher survival rates, they're like Scandinavia, they're years ahead because they've implemented this for a long time. Canada, the Netherlands, they have a school journey, and really from they start kindergarten in the primary one, and that whole journey, they build up this confidence and they build up the pieces of the puzzle. Yeah. Then they get to that stage of Key Stage 3 where then they can perform full CPR and then revisit it again at Key Stage 4.
Yeah. So that's all education. That's all very good. But let's go out into the real world, the public, and you come across somebody. You've already outlined about how you contact the ambulance service and you start CPR and they ask you about an AED. An AED is key. Has there been any advances in the availability of AEDs?
So historically, once AEDs came in, each ambulance service would have kept a record, a database really of where they were, which brings, I suppose, a problem in itself because they're individualised. There was no link between our service and the like of any of the other UK services. It couldn't be monitored and measured, I suppose, the success of it. So the circuit came about that was funded by the British Heart Foundation, and all ambulance services are now on board with the circuit, which is basically a national defibrillator database. So all of the information now on each public access defib is registered on this database, and that's visible to the ambulance service then control staff.
Our control staff have visibility, because I do remember, and it's not in any way, shape or form a criticism, but there were some high profile instances where people suffered cardiac arrest and local communities come together and they say, well, we got to have a defib and we buy one, and they bought it, and one person would have a key, and if somebody collapsed, where is Michael tonight? Is he away and on his holidays or whatever, But now the system works. You phone 999 and our control staff will tell you what.
So just before that whoever has bought the defib historically, the like of a sports club or whoever, and they may put it in a lockbox, the national directives to have it open. That's another argument. So that information is logged on the circuit. So any access codes, exactly where it is in the building, you can drop a pin to show exactly on the map where it is, and all of that information then is visible to our control staff. So should the call be categorized that an AED should be deployed, they can see that information. It's live information from the circuit, and they can pass that direct to the caller to retrieve a defib.
And have you any idea how many AEDs we have throughout the north?
We literally just hit 4,400 overnight.
That's a lot.
I had a figure for you yesterday, and we've hit 4,400. And yes, statistically per head of capita, we actually have quite a few compared to some other UK regions.
But I'm sure you would still like more.
Absolutely. Right. And it's not just about the amount, it's about the placement of them too, the optimum placement of them.
Well, that's what I was going to ask you, because it's public access defibrillation, right? And you were talking about like a pinpoint in an office where it is. But what happens after 5 o'clock if that office is closed? Is there much of that, or is the number of that are really 24-hour accessible, is that increasing as well?
That's the big piece of work really, John, that's ongoing at the moment. So the big push initially was to get defibs and register them, but now we're looking at, and with help from the circuit, we're looking at how many are accessible 24/7. So what we have is a guardian for that defib will do a checklist, and they will tick the defib's emergency ready. So that will show to our control staff. The problem with emergency ready is it could be limited access, as you say, an office. They're 9 to 5, Monday to Friday. Well, you can actually look statistically and say at the weekend the pool of available, not just emergency ready, because it can be emergency ready and not available, that can drop by up to a third at the weekend. So,
Yeah.
so you may have 4,400,
Yeah.
but at a weekend, you take a third off that.
Yeah.
Vastly reduced.
So, do we practice what we preach?
We do. Not even 2 years ago, we had 35 public access defibs installed outside ambulance premises, which was great because it meant we could practice what we preach. We encourage businesses, we encourage organisations to have them. We encourage them to have them outside. We encourage them to have them 24/7. But we've done that. We've got them all in boxes outside our premises, and it means that they are available for the public. And we are now auditing those as well every 6 months to see how effective they are. And if they're not being used, then we can revisit and perhaps replace for the greater good of the
public. And I think they're highly visible, aren't they?
They are.
The people within those communities will walk by them and they'll know it's there. So really, if an instance of cardiac arrest occurs, it might not even require our staff to tell them this is where your nearest defib is, They'll know exactly where it is. And even the ones that are sitting outside shops, the fire service also, they put them at their stations as well for public access, which is a great thing, so there may not be that need. So all we be saying to the public today is acquaint yourself with where it is, because cardiac arrests don't happen by appointment. Absolutely. You never know. You never know.
And the key thing in that is that even though you may know where it is, phone 999, and they can then, once they see what they'll allocate that defib to the call, which means it drops off the circuit, and that mitigates against another incidence of cardiac arrest and someone going to retrieve a defib that someone has just lifted.
And of course, they would need to call 999 to get the code, because they're all protected by a code, aren't they?
Well, those that are, And again, the national directive is to have them open.
Mm-hmm.
And that creates a bit of fear for people, because they think, well, it'll be stolen, it'll be damaged and all of that. But actually, the circuit, they have data on that. I think there's 5 incidences that defibs have been reported stolen ever in Northern Ireland from the start of the circuit. And that's sort of a 6-7 year period. And there was 13 that were logged as being damaged.
Yeah.
Now, out of those, most of them were locked, the damaged ones.
Yeah.
And you could argue that the fact that the locks are on those, and in that panic, and trying to remember what the code, turning the handle the wrong way.
Yeah. No,
and I can understand how the door could be forced, and that could be a lot of the damage.
No, that reflects very well on the communities within the north here. That Northern Ireland, we tend to put a great importance on community safety.
Yeah,
because we do know that, for example, a defib sitting in the middle of the city centre will help somebody there, but people up in the west of the city, the north of the city, it's not going to be helping them. So everybody will take their own community. Anything that helps the community, and they'll cherish it. And that's absolutely a good thing.
Yeah.
And we're talking about the city. We're lucky. Ambulance response times in the city are obviously going to be much, much quicker. Mm-hmm. Obviously, because we're 4 stations here in Belfast, and we cover all areas of Belfast, and we get there within a matter of minutes, so increasing the chances of survival. But once we start heading out into the rural areas, the delays in us getting there, with the best will in the world, some of our ambulances are not 8 minutes away from any scene. What has happened in recent years to assist us in that?
So from about 2018, now there were some of these groups set up before that, but NIAS, I suppose, took them under that umbrella, and we provided that governance and oversight and support for them. Their community first responder schemes. And really, you're right. The basis of why they were set up was the rurality was really the key, and that prolonged ambulance response time. So across the province at the moment, we've 25 different community first responder schemes, and I think it equates to 461 volunteers at the moment. So what they do is they volunteer their own time. They come for some training with ourselves. We do a 2-day sort of tailored course, and I say tailored. It's not accredited, but it's tailored to the calls and the code set of calls that they may respond to for us.
Mm-hmm.
So they'll attend that, and then they'll go back to
how do they get notified of this?
So it's a slightly different model here than it is in the UK. So most of the UK services have direct volunteers for the trust. So community first responders will be funded and managed by their individual trusts. Here, they're set up as independent schemes. They would normally have charitable status or set up as a community group. They'll self-fund then, they'll fundraise. They'll be set up with a committee that would oversee each individual scheme, and they'll have a coordinator who will pull all of that together, and they would be their main, I suppose, the main point of contact for us. They will recruit, we'll provide the training, and when they go back then, they'll be put on it's called an alerting list. And at the moment, the system for that is an SMS text, which automatically generates from our control automated dispatch system.
It's automated. It's not a chance of somebody sitting down and controlling it and suddenly going 5 minutes, oh God, I forgot to notify them.
Yeah.
That goes out.
As soon as that's hit, that category.
And how often would they be used? How often do they respond?
They have literally thousands of alerts are sent. Now, you couldn't expect that they would respond to them all. Yeah. Because these guys are giving up their own time. A lot of them have full-time jobs, and they can't do everything. But some schemes have as much as a 1 in almost 2 response to alert ratio, which means for every 2 responses, like, they are attending one of those, which is fantastic. And I suppose the premise for it really is to what we alluded to, that early life-saving intervention. So most of these guys will carry an AED, so they're bringing that, and because they're in that locality, they are generally there before ambulance crews, and they can deliver that real, life-changing and life-saving skill.
And have we any evidence of instances whereby the community first response team have got out and have done the key stuff of early defibrillation, and our crews arrive and the patient survives? Is there many instances?
There are, and there's one not too long ago. I mean, I'll not go into details, obviously, but a public access defib actually was retrieved. Community first responders were there. The person had recognised that cardiac arrest and called 999. All the components really of the chain of survival that they worked, and a community first responder was there as well. When ambulance arrived, this patient had an output, which was absolutely fantastic, and the person has now made a full recovery.
And that must be really uplifting for that whole group. You know, that one of their representatives was there and looked at that and gives them the inspiration of. They may never have had a call. They may be in operation 4 years and never had a call because of the remoteness of where they are.
Absolutely.
But as I say, the cardiac arrest doesn't come by appointment. You never know where it's going to happen, So, and that's really, really good that there are those successes, and I'm really, really pleased with them. There is another initiative ongoing throughout the UK at the minute. Good Sam.
Good Sam, yeah, absolutely. So that's slightly different in that
Good Sam being short, I assume, for Good
Samaritan. Yes. Yeah. So it's a smartphone app, and you can sign up for that. If you've done first aid, you must provide some evidence of a first aid course having been done, and that's part of your criteria to join. So that gets checked, and then you've signed up to be alerted if within a 500 metre radius of where you are at that stage, a cardiac arrest comes in. Then again, through our control system, our computer aided dispatch system, that automatic alert will go. You'll receive it through your smartphone app, whereabouts it is, and you'll go with your 2 hands. You don't have to go with equipment, but you're trained in CPR, hence why you've signed up, and you can provide that within minutes because you're 500 metres away.
Yeah, but still, at the same time, you wouldn't want the message to go out to anybody who isn't trained that if somebody claps in front of you, don't worry, somebody's going to come with their cape on and Good Sam and start doing this for you. It's key that you start it.
Absolutely.
And if somebody who is more medically trained comes along and says, thank you so much, can you give me a wee hand here? I'll take this over.
And the thing about that is, that telephone CPR, those instructions will still start for the caller at the time.
Yeah.
And this will happen in the background, which is...
And so in terms of CPR training, we don't do that ourselves, sure. We don't for the members of the public.
Well, we do. We try to facilitate it where we can. We have, unfortunately, I mean, the ambition would be to train everybody. That's what the overall goal would be. But as a small team, we don't have capacity. So I suppose ad hoc, we will provide some training sessions. We would be contacted by community groups, sports groups, things like that, who would say, we've just purchased a defib. That seems to be the main driver for a lot of these things. Could we have some CPR and AED training? Now, as a team, we will go out and we will facilitate that, which is great. I suppose the flip side of that is, whilst you're out and teaching CPR to 15 people, really good. That's taken an hour. Is there sort of systemic changes that you can bring in that make that more impactful and the reach bigger? And I think that's, I suppose, what I would aspire to do.
Yeah.
You still want to reach, but you want to reach further, and you want to reach with what you have and make it more impactful.
Yeah, and given the limited resources that we have to do that, there are organisations who do provide first aid training and CPR training as part of that. And people, if they've interest at all, should make that contact and involve themselves in groups. Are the CFR groups only for rural communities?
No, they're not. No. In fact, there's some that are looking to start more inner city. There already are some that cover some of our cities and towns. Historically, yes, that was the premise of why they were set up. But as you said, within Belfast, there's 4 stations.
Mm-hmm.
But the hospital structure and who goes to what hospital has changed. So a lot of the time, a lot of the ambulances may be in Belfast
mm-hmm.
or across the province at the main hospitals, which leaves other places that maybe historically had cover. And let's face it, the demand on the ambulance services then was a lot less than it is now. So there would have been that ambulance close by. If a town had an ambulance station, generally you would have had an ambulance on station.
Yeah.
Now, not so.
Yeah.
So, you're talking, it could be a long, long time. So yeah, it's creating a massive difference then in that public preparedness and the public readiness. And these are people within those communities that are prepared to go and do that. And they're there within minutes again.
Yeah. And so I said about individuals, if they want to get CPR, where do they go to? How do they contact us or whatever? If somebody is interested in setting up a community first response group, where do they go?
So we do have information on our website about that. They'll contact us initially. Unfortunately, due to the small team, it can be difficult to do that early. But there's a lot of steps.
Is there a certain number of people must be in the group before it can be established?
Not really, but what they do need to do, because of the independent setup over here, which is slightly different, as I say, to the UK, they will need to set up that committee. They'll need to start, some means of fundraising, possibly register for charitable status to make it sustainable, appoint a coordinator, and then recruit. And once they've sort of recruited people who are interested, they'll approach us and say, can we have training? And we'll build that in. What we try to do at the minute is 3 or 4 initial CFR courses per year, of up to about 25 people. So really we've capacity for about 100 new CFRs per year.
Yeah.
And that's how the model.
And when they're established, there's governance. What is our governance entail?
So clinically, obviously, we stand over anything that's done clinically.
Yeah.
Each scheme, again, they would have policies. We give them guidance on what policies to introduce and implement. We try to standardise that because it makes it easier, on the whole. However, because they are independent, there is a lot of onus on them to self-govern, but not clinically. We have clinical oversight.
Yeah. So look, thanks for coming in and bring it to a close. Out of hospital cardiac arrests are an issue. 1,400 is too many people. There's too many families losing a loved one because of that. We'll do what we can in terms of our ambulance response. There are community first responder groups. There's Good Sam. But would bystander CPR improve things even further?
It would certainly improve the survivability, and that's been proved.
And we would encourage people to get down and get on it. No worries about breaking somebody's ribs, because if you don't do the CPR, they're going to die.
And listen, as an ambulance service, it can happen. We can perform CPR, and you can have cartilage pop, you can have ribs break, but you'll keep going. And the key thing is keep going. And we would say any CPR is better than no CPR. But to be trained in good CPR, chances of a good outcome. And I think that's the difference.
Yeah.
The better the CPR. So therefore that training, absolutely. And it is about the public awareness, which is why we will endeavour to attend some public awareness sessions, public engagement at big events. We've collaborated with the Air Ambulance NI for a couple of things like the Marathon Expo, heavy footfall. It creates that awareness. People then become interested in learning CPR.
Yeah.
And the beauty about it is, once you've learned CPR, you might tell a few other people who then want to learn CPR, and you nearly get a cascade effect as well. And even the pupils in schools can do that as well.
Yeah. So then, in closing then, what's your vision for out-of-hospital cardiac arrest strategy?
I mean, it ties in with the initial strategy. and in a nutshell, to have as many people confident and competent to step forward and perform CPR. And in essence, that will affect the survivability from out of hospital cardiac arrest, and you want that figure to rise.
And the survivability, because of the high number that take place in the home, means it's your loved ones you're going to be saving a high percentage of cases.
Absolutely. Which gives an added incentive to want to.
It absolutely does. Michael, thanks so much for coming in. You're obviously passionate about your whole role, and I hope it comes across, and I hope your phone gets inundated with phone calls from people who want to do this, and then you'll be cursing me. But absolutely, thanks so much for coming in.
Cheers. So
there you go, everybody. Do think about, cardiac arrest can happen anytime, anywhere, to any person. There's no age limit, either lower or higher, on cardiac arrest. It happens right across all age groups within the North, and we would encourage you, please, just consider acquainting yourself with the principles of CPR. And if you do see somebody collapsed in the street, don't be the person who walks on by. Be the person who at least gets down and offers some kind of assistance, some kind of comfort to the person, and if required, and advised by ambulance control, commence the CPR. You'll not be doing any harm. So thanks very much for tuning in this week, and we'll catch you again very soon. Take care.